Good afternoon, everyone, and thank you, SRNMCON, for inviting us for this important topic, which is close to us. Working since last 19 years and running a dialysis service chain. So this is a very important topic for us. So I will.
This entire session of Mythbusters was Dr. Rajesh Kumar's brainchild.
No, thanks. Thanks, sir. I will take it in the four important headings. First is the busting of myth for hyperkalemia in a hemodialysis patient. And starting with the first case, Mr. aged 68-year-old male, chronic kidney disease stage 5 due to chronic glomerulonephritis and also having a hypertension, on maintenance hemodialysis since last 3 years. And he was also having chronic hyperkalemia since last 3 months. Every month when the routine investigation was done, it was showing a high potassium level. And he was also having a recent admission in the hospital with the potassium of 7.9. He was sent to dietitian for detailed diet interview. But before asking the dietitian to take over, I will want to give you some important evidence that hyperkalemia in dialysis patients are very common and very dangerous event. It is very unpredictable. We can't predict, and it is a very can cause lethal arrhythmia, which can include cardiac arrest. It can also cause respiratory muscle weakness and respiratory depression. And patient may complain of sinking feeling और हाथ पैर ढीला पड़ जाना, मतलब गिरने का मन कर रहा है, लग रहा है गिर जाऊंगा मैं. It is like a common symptoms what patient used to tell us that sir हाथ पैर ढीला पड़ रहा है, there is a weakness and muscle fatigue. So we all know that hemodialysis is the primary method of potassium removal in such patient. But we have to also understand the limitation of dialysis for potassium removal. There will be a decreased removal if you have got, because on dialysis you are correcting the metabolic acidosis with the bicarbonate bath. We are also sometimes giving a glucose containing dialysate, or patient may be taking an insulin or beta agonist like ethylene nebulization and all. So all these scans, because we know that the potassium is removed from the intravascular compartment, that means extracellular compartment, and majority of the potassium are staying in the intracellular compartment. So potassium has to come out from the intracellular to the extracellular to get removed on dialysis. So if that shift is not taking place quickly, then the potassium removal will be less as compared to what we desired. There will be increased removal if you have got a hypertonicity or high sodium dialysate, or patient is on beta blocker. So we all know that we are restricting the potassium, and every day 40 to 60 milliequivalent of potassium was taken, almost 300 to 400 milliequivalent in a week. And we all know that 100 milliequivalent, almost 70 to 100, depending upon the blood flow, dialysate flow, and the efficiency of the dialyzer, we can remove the potassium every session. So almost 300 milliequivalent of potassium in a week if a patient is taking thrice in a week. So almost a depletion gap of 25%. That means 100 milliequivalent of potassium gap is there, where the patient will have that much of retention. So that retention, some part is taken care by the colonic secretion of potassium, which is almost 5 to 10%. That means 10 to 15 milliequivalent are removed by the gastrointestinal tract. But for that also, patient need to have a good motion. And most of our dialysis patients, we are removing the water, and that is causing constipation. So this part is also having problem. So what we do a low potassium dialysate or potassium free dialysate. And we all know that when we are having a sudden change in the potassium level in the body because of the low potassium or K0 dialysate, we are having an increased tendency for arrhythmia and increased mortality. You can see in this study, almost 82,000 patients were studied for 3 years. You can see that if the patient is having low potassium or high potassium, the 3-year crude death rate was quite high. And when you are decreasing the dialysate potassium also, the mortality is high. And we have also seen that the need for cardiopulmonary resuscitation, that means a cardiac arrest event. In this study, almost 38 patients suffered from this, and the most common day of cardiac arrest was on Monday or Tuesday, when the 2 days gap was there, and most common cause of this cardiac arrest was hyperkalemia. So we understand that there is a limitation of dialysis in potassium balance, And what are the limitations? Because I have discussed that almost 25% of the gap is there. And we know that when you are giving a potassium-free dialysate, we have got a fluctuation in the potassium removal, which can increase the risk of arrhythmia and death. So I hand over to Rachna about the observation from the diet recall from the patient.
Thank you, sir, and thank you, SRNMCON platform. In extension to this case, so what were the observations from the diet recall? We found that the patient was taking moderate amount of calories and proteins. However, there was one additional information shared by the daughter-in-law that this patient was consuming low sodium salt. I take you to a case study. Next slide. Wherein we see a case report wherein the patient, there is this patient who has had 2 episodes of severe hyperkalemia, wherein the potassium level is 9.7, and this patient has landed twice into similar forms of hyperkalemia. And as sir stated, this patient was, she developed an air systole and had to be treated with cardiopulmonary resuscitation. And on further investigation, it was secondly revealed that this patient was continuously on low sodium salts. Hence, it is extremely advisable to completely avoid the low sodium salts. Dietitian actually need to be aware about several brands of low sodium salts. Apart of these, there are several dietary additives which need to be taken care of. Next slide. So dietary additives like breads. Many a times what happens is that confectionery items do contain potassium in the form of potassium bromate or potassium iodate, and these confectionery items need these as the baking agents. So most of the well-known multinational fast food brands use these items. So this has to be brought into the notice of the patients that if they are taking any food items with these additives, they have to be restricted. Here I would like to point out a very important myth, that is all dialysis patients, do they need to follow a low potassium diet? Not really. If the patients are able to control their potassium level into a normal range, then no additional benefit is seen by further restriction of potassium. So moderate potassium diet can be helpful. Next slide, please. So I hand over to Rajesh sir for busting myths about interdialytic weight gain.
Second case is a 59-year-old female on maintenance hemodialysis since last 7 years, known diabetic and hypertensive, and also suffering from ischemic heart disease and the heart failure with very low ejection fraction of 20%. Her dry weight is 59 kg. And if you see the session wise interdialytic weight gain, first 4.2 kg, then 3.6 and 3.5 kg, with the average interdialytic weight gain is 3.7 kg. When the 2 days gap is there, 4.2 kg, and when the 1 day gap is there, 3.6 kg and 3.5 kg. So we all know that to achieve ultrafiltration goal on dialysis, there is the limitation, and we all know that we have to keep the ultrafiltration rate of less than 10 ml per kg per hour. That means a 50 kg patient, we has to remove maximum of 2 liters of water during the time of dialysis. So there is only 2 options left for us. One is to restrict the interdialytic weight gain, which is conflicting. Every time fight is happening in the dialysis unit between the technician and the patient, and which is often unachievable because patient is not listening. Patient has got their own thinking in their mind, and that is the reason these things are very, very difficult. And second thing is also very difficult for the patient, because to extend the dialysis duration for more than 4 hours to 6 hours, or giving additional dialysis, which is also very difficult because patient is not ready for 3 dialysis, he will not be ready for 4 dialysis. So we have to achieve this goal to protect the heart, because we all know that if the intradialytic weight gain is more and a patient is already having a poor cardiac function, so the cardiac function will not going to get improved and it will go on declining. So we also understand that tolerance is determined in the dialysis patient for removing the fluid by vascular refilling, and that refilling rate, because we are removing the water from the intravascular compartment, and most of the water in the dialysis unit is, dialysis patient is in the extravascular compartment, that is in the interstitium and the outside the vessels. So that water has to come back in the intravascular compartment to get it removed. So there will be a plasma refill rate. So rate of intravascular filling contraction, or that means removal of the water from the intravascular compartment, should be equal to plasma refill rate so that the patient should not have hypotension. If the intravascular contraction or removal rate is much more than the plasma refill rate, patient will start getting hypotension. And in this slide, we can see that the cardiovascular mortality go on increasing after the ultrafiltration rate has increased from 10 ml to 15 ml, and which is almost 40 to 60% more than the conventional patient. So it was also there is the incremental and almost linear association between the ultrafiltration rate and the mortality, irrespective of the gender, race, age, and urine volume and the dialysis treatment time. So there is a limitation of dialysis in achieving the fluid and salt balance. So sometimes patient used to talk about, आंटी इतना पानी क्यों पिया, आप इतना कहाँ से पीती हो, क्यों पीती हो आप. सो पेशेंट कभी कभी बोलता है आपने पानी का बोतल दिया था, जो मेजरिंग बोतल था वो गायब हो गया, अभी वो नहीं है, डायलिसिस पे भी तुम लोग पीने नहीं देते हो और ये सब खाने भी नहीं देते हो. So in one of the study also it has shown in DOPS that if you are increasing the ultrafiltration rate, that means if you are having interdialytic weight gain of more than 5.7% of the dry weight, the overall all-cause hospitalization, cardiovascular related hospitalization are much more as compared to a patient who has got less than 1% of the dry weight interdialytic weight gain. Over to Rachna.
Okay, sir. So here it is very important to know that technician probably may have missed this part, that the patient has
Rajesh,
got
your
the bottle that
discussion is going
contains
fantastic.
measurements. This leads to
So-
drinking water based on personal judgment. If the patient is drinking upon personal judgment, the patient is going to tend to have
Can
an
we
excessive
summarize?
intake.
The
So
time is
here
up. Can we summarize?
Yes, sir. Sure, sir.
It's very good discussion going on, but unfortunately we have time limits. So can you summarize?
Sure, sir. So we will stop here. And here the average interdialytic weight gain of the patient was 6.2. However, it is supposed to be less than 5%. Here we are seeing that approximately 1 liter of swelling that the patient is having may contain approximately sodium, which is equivalent to 7 hot dogs. So with this, I can end my
Tarun,
talk.
please check the time because we are continuing. You are in continuation.
I understand it. It's showing up on the timer, Rajesh.
No, that
The
is
discussion
wrong.
is excellent
See,
going on.
no, Tarun, the timer is because the dietitian is getting 5 minutes, I am getting 10 minutes.
I understand
So
that.
I don't know
Let
whether.
the organizer decide. Do we have
Yes.
more time, Dr. Umesh? Because it's very interesting discussion going on. Very interesting facts, common myths, and common problems with dialysis patient. Do we have 4 or 5 minutes left, or Dr. Khanna?
I think you have.
Yes, please go ahead, Rajesh. But make it brief and
Sure.
precise. Yeah.
One important myth associated with this patient was that the patient was asking whether cooking water should be considered as fluid. However, not if they are using it only as soups, they should consider it as fluid, otherwise not. Over to you, sir.
So third case is a hyperphosphatemia in hemodialysis patient, 69-year-old male, hypertension, having a vitamin D deficiency and secondary hyperparathyroidism. And he was having a high phosphorus. We know that the high phosphorus level is a major mortality risk factor affecting almost 50% of the dialysis population by causing secondary hyperparathyroidism, vascular and soft tissue calcification and death. So phosphate intake is approximately 800 to 1500 milligram. We all know that with the increasing protein intake, phosphorus is going to go up. So almost 1000 to 1500 milligram every day, that means 7000 per week. And we know that only 3 ways we can take care of this phosphate balance: by diet, phosphate binder, and the hemodialysis. And we have to understand that the dialysis has got limitation. With the conventional dialysis, we can able to remove 2 to 3 grams of phosphorus. That means almost 4 grams are left in the body. If you are giving an extended dialysis or nocturnal dialysis of 8 hours, that we all know that the nocturnal hemodialysis patient maintain the phosphate without having any phosphate binder, because they are able to remove almost 5 grams of phosphorus. So they can maintain the balance without having a phosphate binder. You can see the limitation of phosphate binder. So whatever is remaining inside the body, we have to take almost 10 tablets of calcium acetate every day, which can increase the calcium overload. So there is a load of pill burden, and there is an inadequate removal by the conventional dialysis. So the role of dietitian recall is there, diet recall is there, and the fast check. Rachna.
So what happens is most of the times it is always seen that the patients who have extreme affinity towards foods with food additives, they land up into hyperphosphatemia. Next slide, please. So every dietitian needs to have a protein to phosphate ratio ready reckoner as with her, and she can select foods which are having more of a protein content but a less of a phosphorus content. Again, over here, it's very important to know that inorganic phosphorus is almost 90% absorbed by the intestines. So all the previous food items that were said which contain a high load of inorganic phosphorus should be restricted. Next slide. Here you can see that egg white is a ingredient which is having a very low phosphate to protein ratio. Hence, egg white can be a very good source of protein as well as less amount of phosphorus burden can be created with it. Next slide, please. Over to you, sir.
So this I will conclude, and I will hand over to Dr. Tarun.
So you have time actually. The
We have
event
time.
manager gave you only 10
Carry
minutes.
on, Rajesh. Please
You
carry on.
sir. You have time.
Okay. So this this is the last case. This 64-year-old female on APD since last 8 months and having a diabetes and hypertension with the peripheral vascular disease with a height of 148 centimeter and weight of 39 kg. Her albumin reading was 2.7 gram in July, which was going on decreasing trend with a 2.2 in the August and September 1.8 gram. So dietitian reference was done for the diet counseling. And Rachna, you can take over from there.
Sure. Herewith, I would like to share a study from the journal named Nutrients, which states that the patients who have intake less than 0.73 grams per kg per day, a dietary protein intake of less than 0.7, they have worse outcomes. However, the outcomes could be worse if they develop peritonitis. Next slide, please. So a very important myth associated with this case is that vegetarian patients, especially Jains, cannot obtain adequate proteins. However, the fact is that if they select, the selection of protein is very, very important here. A dietitian can help them select proteins with a good cereal and pulse combination or a milk and cereal combination. And then their amino acid sequence can come as close to high biological value proteins like egg and fish. So this should be incorporated into their meals. Thank you.